I'm afraid to even move. Connecting. Hello.
Hello.
Oh my gosh, this is so exciting. Let me plug my phone in because if that were to die, I would lose my mind. I would just lose my mind.
I just got your acceptance after all this.
That's insane. Thank you so much. I'm plugging my phone in. Hold on. Thank you so much for bearing with me. I don't know what I'm doing. This is completely new for me. So, okay, everybody, we're on. We've got like 25 people. Hold your questions, please. Just hold them because I'm going to have to scroll through everything. And let's just get started. I'm going to turn off all of the questions here. Hi, Dr. Prakash. How are you?
I'm good. Thank you for your perseverance.
No problem. And my jazz hands and my improvisation. Well, welcome to our live event being broadcast between Houston and Maryland. This is a first for us. So we're really excited to be able to do this and have you here. One of the main reasons I wanted to have you here is because when I saw your presentation at that John Ritter community symposium, we were all very impressed, very impressed. It was a presentation that really resonated with all of us. It was easy to understand. And it, even for some of us who have been survivors for over 18 years, we took a lot from it, which is great. So one of the things I wanted you to do first is take a minute, introduce yourself, give everybody a little bit of better understanding on your background.
Right. So I trained initially as a genetics researcher, and then I did a cardiology fellowship at Baylor College of Medicine. After that, I worked as a cardiologist for a couple of years. I do imaging, reading echocardiograms, CTs, and MRIs before I came here to UT and started my research program in aortic disease. And I've been working here for 6 years. My focus is on congenital heart disease. I see patients, usually young patients and families with heart defects, including bicuspid aortic valve, aortic aneurysms, and coarctation. And I usually follow those patients with medical therapy before and after surgery, and through a variety of complications, which unfortunately tend to happen more frequently than we would still like.
Okay. I want to pull up real quick on my laptop your slides, because that's a lot of what I think I would like us to talk to speak to tonight. And we're going to talk a little bit for individuals that have an aneurysm, that have not dissected, individuals who have dissected, obviously between the two, it would cover both, and a little bit about individuals who might have a connective tissue disorder or a syndrome. So I've shared all of the slides that I think would make a lot of sense to everybody in the community. But one of the things you started off with was talking about when you have imaging of the aorta. And I think there can be some confusion because there's a lot of different numbers, and you talked about make sure you have a gated image. And I don't think a lot of people truly understand what does that mean to have a gated image. So before I even ask that question, what are some of the most important things to make sure have happened when you have imaging, and what would be the most preferred method of imaging to diagnose somebody, whether they have if they have an aneurysm?
Okay, so the most important thing is to know which parts of your aorta are at greatest risk and need to be monitored most carefully, because that will determine what type of imaging is best for you. And everyone's aortic disease is slightly different. So some people have an enlarged root of the aorta near the heart, some a large ascending aorta, and some people have involvement of the arch and descending aorta farther away in the chest. And so depending on which parts are affected, they each have different rates at which they need regular imaging, so different intervals and different types of imaging. As an example, the root of the aorta, where the aortic valve sits, is best imaged by echocardiography. Even though you might think that MRI and CT are higher resolution, they don't handle the speed at which the aortic root moves up and down with each heartbeat very well. And they often make it difficult to measure the aortic root. They're much better for other places in the aorta that are farther away from the heart and not moving as much. So if you have aortic root disease, we recommend regular echoes, but not necessarily regular MRIs or CTs. The opposite would be true if you had disease affecting another part of the aorta, where we might say MRIs are the only thing you need and you don't need regular echoes. So it's really individualized, and starting with anatomy is probably the most important thing.
Okay, so if somebody has, let's say, a bicuspid valve and they find out they have an aneurysm, I'm just throwing out scenarios of things I've been hearing or reading online, and they have an aneurysm on the arch. How the best way to monitor that would be through.
So the arch is very difficult to image in most adults using echo because of the breastbone, the sternum. It obscures most of the arch, and so you can't get good measurements. For that, you would need a CT or MRI, and not an echo. That would be your first choice.
So if somebody is diagnosed with an aneurysm, what would be some of the questions that they should, oh, okay, Stephen, go ahead, type your question, Stephen. But what would be some of the questions somebody would want to ask of their doctor once they hear you have an aneurysm? On whether it's abdominal, it's in thoracic, or it's at the root? What would be some of the general questions that somebody might want to ask?
Sure. So the first thing you'd want to know is, what is the best way to follow the aneurysm? How frequently and what type of imaging do I need? So when to come back is really important, because some aneurysms grow faster than others. And if you wait too long, you might already pass the point at which you could have done something, intervene, and reduce your risk. So I always tell people to make sure that you have your schedule, and each part of the aorta is different. So if you have different parts affected, you might need to come back in 6 months for your aortic root, but maybe every year for another part of your aorta. And that's so each part on its own independent schedule, and you need to know and keep track of that.
And so some of the things, I guess, that we would all hear if you have an aneurysm would be watching your blood pressure, which you had talked about.
Right.
There's been discrepancy in weight lifting and how much. And I think a lot of people they don't understand why they are told they have a cap or a limit on lifting weight. Can you explain what lifting or straining, what that actually then does to the aorta?
Right. So we've measured blood pressure in patients who have been lifting heavy weight.
I think we might have lost you. At least I don't see anything. Does anybody see anything? Anybody? Did we lose the doctor? Does he need to join back in again? Because I'm not hearing anything. I know, no. Dr. Prakash. Panic. You guys hear him? No, he'll join back in again. Get your questions together. Stephen, we'll do our very calls in, then all of a sudden you lose it. He'll be back. He'll be back. I promise. He'll be back. He'll be back. But you can start posting your questions. I will do my very best to keep answering them. I thought I had a plan of how I wanted this to go, but I think that you guys are really going to guide this for us. So ask your questions. He's no longer on my screen. Dr. Prakash, if you can hear me, log back out. We'll try it again. And I'm going to try to send you that invite. And I'm doing it again right now. Let's see if we can get him back in. It says adding. Hopefully it moves to connecting, and we will pick right. Okay, you're back. Sorry, we lost you there. So you were talking about straining and weightlifting.
Yes. So we've done a lot of work with blood pressure and the goals that we should try to aim for. And our estimation is that it's sudden changes in blood pressure and not the absolute numbers that make the most difference, because sudden increases are known to cause aortic dissections. And so doing everything you can to minimize drastic changes in blood pressure should be the goal of anyone who's at risk for aortic dissection. The reason weightlifting is particularly harmful is not necessarily the quantity of weight, but it's the suddenness in which blood pressure increases if you strain. That stress goes directly into the chest cavity and presses on the aorta. And that is the factor that we think causes aortic dissections.
So that
So
could be the holding your breath when you get ready to push that lawnmower up a hill. If you haven't dissected yet, or I would think even if you have, that would be bad too. You are forcing that blood quickly in an area that's weakened or has already been weakened.
right, it's the combination of a rapid and strong and a sudden increase in force on a weakened aortic wall. So
Okay.
you need both of those to happen to cause a dissection.
Okay. So, and getting to dissection, if you've had a dissection, and we're going to start answering some of these questions in a minute, because even though I had a plan, it seems like everybody else is they're directing our evening tonight is what's going to happen. What would be some questions? You've come out of the hospital, you've been released, you're going to have your follow-up. What would be some of the important things that you think patients want to find out about after they've had a dissection?
Probably the most important issue after a dissection is to make sure that you are on the right medications and that you have good follow-up, because a lot of people aren't sure when they get discharged how quickly they need to follow up. What is the issue with their aorta? Should they be checking it every month, every 2 months? And so you need to have a clear plan so that there aren't any surprises. A lot of times what I try to do is see patients while they're in the hospital, or at least make arrangements for them to see me and follow up within a few weeks, because that's a time of great uncertainty, and setting a plan early can prevent a lot of anxiety and uncertainty later if we know exactly what the roadmap is for the next 6 to 12 months.
Okay. There was a couple key things that you had mentioned, which I did not know. Aneurysms do not shrink, correct?
Oh, what do you mean?
Aneurysms do not shrink.
Oh, they do not shrink, no.
Right. So,
No.
but here comes the question. So sometimes people will go in and will be told they measured, let's say by the root 3.9, and at the next appointment, then a new radiologist is saying, well, now it's 4.1. Is that technically growth, or is that that's my interpretation versus that when is it really, oh, okay, I really did grow now? I mean, I would think 3.9 to 4.6 is actual growth, but 3.9, 4.1, is it really? How do
Right.
you know, when should you be concerned at the change between numbers?
So we know that the error just from measuring is about 1 to 2 millimeters. So it's very difficult to say if you get a difference of 1 millimeter to 2 millimeters, like 3.9 to 4 or 4.1, if that is just a product of of two different people measuring it, or if it's an actual change. Anything of more than 2 millimeters is almost certainly real, or it is the result of an image that's not well aligned so that it was measured differently. So the main thing to be sure of is, did they measure the same part of the aorta, and did they measure it using the same technique? Because there are different ways that radiologists and cardiologists measure images.
Okay.
So for that reason, we recommend getting your images done at the same place, and hopefully read by the same radiologist or cardiologist who knows your previous images.
Okay. What was I going to ask you another question? Okay, I'm going to start with taking some of these questions because I know everybody's getting a little excited, and I want to keep you too long because I'm sure you're going to want to have dinner soon. What are your thoughts on stress tests for people who have had a dissection?
So we do use limited stress tests. They're not the traditional kind where you run until you're exhausted, but they're lower level stress tests to see if our patients develop hypertension with exercise. And
Okay.
we do this for people who want to resume activity, but may be concerned that they develop exercise-induced hypertension. And we do know that in the aftermath of a dissection, exercise-induced hypertension is much more common than we used to appreciate now that we're paying attention to it. And of course, that would be a risk factor for either enlargement of the dissected aorta or extension of the dissection if it happened regularly. So before we recommend that everyone has some sort of evaluation before they return to exercise, Daily activities are a little different. If you want to walk, of course, do rehab type things. But people who really intend to become active should probably have some sort of ambulatory blood pressure monitor or a treadmill test to determine exactly what their risk of hypertension may be.
Okay. I'm going to butcher this word, and you may have it on your screen. I'm not sure, but Claudia had a question. If someone has the root of the aorta, the descending part of the ascending, all of these areas have been affected, is it more likely that he or she would suffer with a congenital condition, or could it be vasculopathy? Did I say that right? Talking about a total of seven. Yes, about 7 to 10 centimeters dilation of the aorta, but it's in different segments.
Right. So typically genetic disease affects the root and ascending part of the aorta. And we tend to think of descending disease caused by things like atherosclerosis and people who are older in age and have smoked. But that is, it is absolutely true that if more than one segment is affected, it's much more likely to have a genetic origin that we can identify. And that includes not only the aorta, but if you see the aorta and one of the smaller branch vessels affected, like the carotids or the vertebrals, it is also much more likely to be genetic, and we would search very, very hard for a genetic cause in that person.
Speaking real quick about genetics, I thought I had heard Dr. Milowitz say, and I could have this wrong, that typically having an aneurysm, I'm not talking about when you're in your late 70s or 80s, but having an aneurysm when you're considered relatively younger just doesn't happen because it's a Wednesday. That having an aneurysm or a dissection without it being a trauma, or if you didn't have high blood pressure, would more than likely be something genetic. Do I remember that correctly? Did I hear that correctly?
Right. So it's very unusual to develop, even with extreme levels of hypertension, a significant aneurysm. Almost always, we believe they are caused by genetic factors. We can't find them in a good proportion of cases, but we consider them in the same way as we would with someone with any other familial aortic disease.
Okay. Good question from Stephen. Right now, he's having gated CT scans every 6 months, but wants to know, and I'm curious too, because I've probably just in literally the last 12 months, not just this last year, I've probably had 4 or 5 CT scans. So what kind of risks do we have? I mean, other than we probably glow in the middle of the night, but what kind of risks are we facing? I think a lot of people are scared at the amount of radiation, and I'm just curious to know really how much is it? And obviously, the pros and cons, it makes sense to have it done, but do we really need to be concerned about the amount of radiation we have with each scan?
Right. So each single CT scan, you should not be concerned. But if you're having, several per year over a lifetime, that does greatly or significantly increase your risk of cancer. Mm-hmm. So it is not. The estimates are around a 20% increased risk, which is not insignificant. For people who have had, 10 to 20 years worth of CT scans, that it begins to add up. Now, CT angiograms, which they typically use to evaluate the aorta and other blood vessels, use slightly less contrast than some of the other methods, the high intensity CT scans for pulmonary embolism, for instance, because they're not quite as detailed. But still, it does add up. And that is a major concern if you're a young person who's going to scans for the rest of your life. Right. That's why I recommend that most young people start off with MRI scans. MRIs are much better than they were 5 or 10 years ago. And they now give us practically equivalent information to CT scans without the radiation.
Okay. So that is something that we can all take back. We should all be taking back to our surgeons and cardiologists. Are we able to have an MRI? Did we make it to the point where we can have that now for this scan instead of having a CT? Right. Okay. Faye wants to know, what is the risk of having other types of aneurysms if you have a bicuspid valve and an ascending aortic aneurysm? If you already have the ascending aneurysm, you have a bicuspid valve, what's the chance of having another portion of your, let's say, descending become effective? And should you still get scanned?
So the answer is it's very low, but we do know that in people with bicuspid valve who also have, say, coarctation of the aorta, then it's greatly increased. So if you have another defect in your heart also, like a ventricular septal defect, a hole in the heart, like an ASD, then your risk of having other aneurysms does go up. But for isolated bicuspid valve, it mainly is the root and ascending aorta that we watch. It's very rare to find another part of the aorta affected, except in patients who've had a dissection. And then in that case, the dissected a part of the aorta would be at risk.
Okay. And so this leads into the next question. What are the chances of rupturing after you've already ruptured once?
So if you have a dissected part of the aorta, there's always a risk of rupture. That risk is never zero. And that risk is independent of the size of the aorta. So we do know that it does increase if the aorta enlarges, but we know that dissected segment will never be of normal tensile strength, and it can rupture regardless of what may have happened before. So the answer is any residual dissected aorta is at risk for a second rupture.
Okay. Lisa asks, so I'm not sure what her question is about margin of error. Why is the interpretation of measurement changes different by a radiologist reading it than a cardiologist? I've read some things that say, well, of course, radiologists write this, you shouldn't have your cardiologist read it, and cardiologists are saying, no, let me read it. And I know mine will place the films on top of one another to actually take a look at any changes. But why is it different?
So different readers use different ways of measuring the aorta. So some people measure across the entire outer portion of the aorta, the aortic wall, and include that in their measurement. Other people go from what's called inner edge to inner edge, meaning just the lumen or the part where the blood flows. Mm-hmm. And that itself will change the measurement by 2 to 3 millimeters. The other way that it's different is that radiologists use views that are not equivalent to the views of the aorta that we get on an ultrasound or echocardiogram. Those views tend to be related to the absolute axis that the radiologist can slice the body any way they want to using a computer, whereas we're limited to the number of slices we get on an echo, and it's dependent on where the probe is put when the ultrasound is done. So the views are not exactly the same, and the measurement techniques may be different.
And another question, I think I might know the answer to this, I can't believe it. If you have an aneurysm near the root, and you have bicuspid valve, but let's say your valve, you don't really have a high degree of any insufficiency, or it's mild to moderate, and your aneurysm, though, is approaching 5 centimeters if it isn't already, are you in some kind of danger zone? I mean, at what point, because I've also heard some people say that their valve was severe, but the aneurysm was only 4. So which causes which scenario to say we need to go in and do surgery?
Right.
Does that make sense?
So I think you might be asking about the relationship between dilation of the root and regurgitation.
Yes.
Because as the aortic root widens or dilates, then the cusps of the aortic valve may be pulled apart, and this can lead to aortic regurgitation. Just because you don't have aortic regurgitation doesn't mean that your aorta is fine. It can be quite large in some people because we're all born with a different shape aortic valve, and some people just can tolerate more enlargement before they develop regurgitation. That doesn't mean you're at less risk of aortic dissection. That is still dependent on the diameter and whatever genetic cause of your disease may exist. So it's a completely independent kind of calculation. We may feel like your aortic valve could last for years, but you still need urgent aortic surgery because of the risk of dissection, or the other way around. The valve may give way, requiring urgent replacement, but your aorta could have lasted for years. In either case, the surgeon will take both of them to prevent the need for a second surgery. Okay.
I have another question here. I'm just going to read it, and we'll see if we can. You still have time with us, right? Are we okay on time? Okay. So Kathy says she's 51 with BAV and ascending aorta is dilated 4.9. Hasn't grown much over the past couple of years. Doctor moved her to checking out just now yearly. Does that seem okay if you have BAV to be checked out yearly? She also had a child with tetralogy of Fallot.
Hello.
Oh, flow. Sorry. Thank you. Could she have gotten that because of her having BAV?
That's actually a question that we are doing research on, because we are enrolling families with BAV in our research study. And one of the things that we're looking at is the existence of other congenital heart defects in families with BAV. We know that it's increased substantially among compared with families without BAV, but the kinds of defects are still being debated. So we know that other kinds of defects that affect the left side of the heart, like mitral regurgitation, like coarctation, like aneurysms, are increased in families with BAV. But the relationship between that and other defects like tetralogy of Fallot is not widely accepted. I think that there are probably more families like yours that have multiple types of heart defects, and we need to study those so we can really understand what the relationship is between them. There is no genetic relationship that is known between bicuspid valve and tetralogy of Fallot currently, but I think that's only a matter of time.
Now, if she wanted to participate in research, would you be someone she would reach out to, or would it be through JRRP?
You can do both, because we're on the JRRP Facebook page, and we do get a lot of requests referred through them. We also have our own study where we can enroll everyone remotely by mail. You don't need to come in for a visit or anything from anywhere in the United States. And we do reach out to family, and we try to talk to everyone about the genetic findings so that we can understand how they impact families. We have genetic counselors here as well to help.
Now, would that go through Ellen Hosletter?
Yes. So Ellen is our genetic counselors, and we also work with people in Texas Children's Hospital here on our study, and several places around the country.
Okay, so I will post all that information. We will post all that information again about contacting JRRP. We've done some work with them already now. Okay, so Laura has Ehlers-Danlos, has 4.6 TAA. She's 58. At what point, so I know everybody's different, but at what point would somebody then have surgery? And she does not mention if she did, it's TAA. So at what point really is it recommended to go in to have surgery, whether it's thoracic or abdominal? What would be the measurement? And especially given somebody who has Ehlers-Danlos.
Right. So she may mean there are two types of Ehlers-Danlos. There's the vascular form, which I assume is the one that she means. Those are caused by mutations in the collagen 3 gene. Those cause dissections with relatively small enlargement or no enlargement of the aorta, as well as other blood vessels. So if you have a COL3A1 mutation, that would be an indication for replacement of that aorta, because we know that dissections are more likely to happen at smaller diameters, as opposed to someone with a bicuspid valve and no known genetic defect. In that case, we know that we have time at 4.6. It's not urgent to replace that aorta. So it really depends on the underlying genetic mutation. And if she hasn't had genetic testing, I would strongly recommend it, because it will help make that decision.
Okay. I'm just rolling through these real quick. We're just going to I'm trying not to do any duplicates here, but somebody who has AVR replaced with mechanical valve now has an aneurysm. It's 5.2, has a question. And if the aorta is replaced, and I'm assuming it's with a dacron graft, doesn't that outlast us, or that doesn't get replaced? I mean, typically, what would be the life on a graft?
So the only time a graft would get replaced is if there was an infection, or they needed to sew to do another surgery where they would sew around or next to the graft. It really should not degrade on its own. So it's absolutely true. It should last a lifetime and beyond. And hopefully that's the reason why we recommend it as the definitive surgery, to treat any sort of abnormal aortic tissue, and that's why we try to remove as much of the tissue that we think is abnormal when we put the graft in.
So a doctor says that somebody has an enlargement of the aorta, but there's no aneurysm.
Right. That's a difficult one because people will define enlargement in very different ways. Aneurysms are generally defined as an enlargement of the aorta more than twice what the normal, quote unquote, normal width is, or more than 95% of the population of the same age and size. And so that's why we use Z-scores, because they help us define what an aneurysm is. But a lot of people don't use Z-scores. And so an aneurysm is whatever is larger than they usually see by a substantial amount. It could vary from provider to provider. And you can see how problematic that is. If you go to one person who says your aorta is enlarged, the next person might note that it's completely normal, and can lead to a lot of confusion. So we advocate using common standards so that everyone understands what an aneurysm means when you tell somebody that, because it's a serious diagnosis and people deserve to have to know exactly what the diagnosis means.
So dilation and aneurysm.
Yeah, I don't know what enlargement would mean in that situation.
Right. I would think enlargement, dilation, aneurysm, they're kind of all one and the same, right?
Yes, they're supposed to be that way, but a lot of people use them to indicate something subjective that we really can't understand without an individual conversation.
When you have a descending dissection, first, this person's asking a question. I have a question for their question. Does the blood doesn't necessarily reabsorb into your body as much as it thromboses, correct? So you're basically clotting off the false lumen. Once that happens, your aorta never really returns to its original size, because now actually, technically, I guess your aorta, once it's dissected, would be considered smaller because you have a smaller circumference or area where blood is truly flowing through.
Right. So it depends on what they do to treat the acute dissection. So many times after they repair, let's say if there's a proximal segment of the aorta, a beginning segment that is affected, they will do something called fenestration, which means they actually poke holes in the membrane between the true and false lumen. And the reason they do that is that in cases, abnormal blood flow can affect organs whose blood supply comes from the false lumen. If that, then the false lumen will not actually thrombose. It only thromboses if there's lack of blood flow through the false lumen, and that's allowed to happen by the surgeon if there's no fenestration and no blood flow. So a lot of our patients never have that happen to them.
Okay. This question's been asked a few times, so we're going to get this. Somebody had a dissection and did not need surgery. However, 5 weeks later, went to the hospital with chest pain, was told that she was fine, and all of a sudden ruptured a week later. How normal of an occurrence is this? And why would something like this happen? Why would somebody be told they were fine if they were so close to rupturing?
So we did a study where we found that about 1/3 of people who were admitted to the hospital with ruptures and chronic dissections had some sort of symptoms in the week before they were admitted. And in almost all cases, they were sent home. So this is this is a point where we need to educate providers in emergency rooms and in hospitals, because these patients are at extremely high risk, particularly in the first 6 months to 2 years after an acute dissection of a rupture. Those patients should not be ignored or dismissed when they come to the emergency room, because it's a completely different situation than someone without known aortic disease. And I caution that all the time, because we're used to dealing with it, but we must be very vigilant about these patients. This is the most fragile time when the aorta is still fragile, and any new tear could easily cause a rupture. So in that case, I think the level of suspicion is the most important thing. Keep them in the hospital, control their blood pressure with IV medications, and don't let them go until you're sure that the pain is completely resolved and there's no abnormal blood flow.
Okay. I don't know if it appears as though the lights are blinking in my house, but they're not. I see it on my screen, so I apologize for that. Jean had stated that she's pretty frustrated. regarding genetic testing. She lost both her mother and brother to descending and ascending dissection and can't seem to find anybody to do genetic testing on her family. In that case, since it sounds like she's not getting anywhere with clinical, would you recommend she contact JRRP to go ahead and have it done there?
Absolutely. We would be happy to speak with her, and depending on what type of testing she has, there could still be some clinical options for her. In many cases, we can get that done. If not, we'd be more than happy to enroll her into our research studies and try to identify a new cause of her family's thoracic disease. It's, again, even though we made a lot of progress, obviously we still have a long way to go. So every new family helps, and we would appreciate that. Okay,
we've got a couple more questions, and then it's 10 after 7. I'm going to go ahead and let you go after this. So if anybody has any final questions, you might want to ask this now, but I don't know anything about this. So I'm just going to read this. Do Z-scores really matter? A person's Z-score is greater than 10 with size of 5.2. So should this person consider a second surgery soon?
Yes, Z-scores do matter because a 5.2 centimeter aorta is very different in a person who is 100 pounds than a person who's 300 pounds. We know that because we've looked at a lot of, we measured a lot of normal aortas, non-dissected and not without disease, and the size of the aorta increases just in proportion to body size. That's why Z-scores were created in the first place. So if it's a small person, yes, then this is a very large aorta and it needs prompt attention.
Okay. Here's another one. I'm just going to read it. Carmen asks, back to COL3A1. She was told VUS, likely non-pathogenic, and she does not have EDS, but wouldn't she still need and should be concerned of a recurrent dissection at a smaller diameter?
So the VUS is a very common problem. It's the bane of our existence as in genetics. As you know, we know of a very small percentage of genes that cause disease. And so most of the things that we find are not related to disease at all. We can find something just due to common variation by chance. And in somebody who's had a dissection, does that mean it caused the disease? In many cases, we can't be sure. So what VUS means is that it's likely not associated with the disease. It's kind of an innocent bystander, but there is a chance that we might discover more information about the variant. So the first thing that I would recommend is to call your geneticist back if it's been more than 2 years and find out if there's anything new that's known about this variant. Things change all the time. And something called reclassification happens, meaning if it were VUS 2 years ago, it might now be pathogenic. And that would totally change the picture. The other thing is that if we can't say that it causes disease, nothing about COL3A1, it really can be applied to your case because we don't really know if you do have vascular EDS or not. So the answer is probably not the same scenario as if you knew you had VDS. It wouldn't be something that could be used to make a decision about like something like surgery.
Okay. Betsy had a thoracic aneurysm, and I believe she had a dissection too. Her daughter right now is 38 weeks pregnant, has never been tested, and is concerned about delivery. And is there anything she should be looking for sign-wise? She didn't have any pain with her dissection. Her doctor is aware of the situation. And this is so frustrating for many of us in the community because there are women who might have dissected, didn't have preeclampsia, people who had preeclampsia, who's, as you know, blood pressures through the roof, were never really fully monitored for anything to do with their aorta. And it's shocking to me that this happens. But here's a situation where I don't think genetic testing or any testing was done on her daughter ahead of time. Any recommendations while she's rounding off her, tail end of her pregnancy?
Sure. So I would, since we don't know, in fact, whether she's affected or not, I would hope that she would have had a baseline echocardiogram sometime before she got pregnant, and then at intervals during the pregnancy to see if there's aortic enlargement, if there are any warning signs. We do know that the biggest risk predictor of dissection when we are following a patient is enlargement of the aorta over the second pregnancy. So if we see that, we would then consider her to be high risk. There can be drug therapies that are started. There can be, she should work with her OB or MFM for delivery methods that require less pushing. So no vaginal delivery, maybe C-section, because those things do increase the risk of dissection. So all of these things can be put in place. I think the most important thing is for her to have a plan in place if there is some real concern about her aorta for delivery, to minimize her risk. And hopefully, you know, the other thing is, of course, to make sure that her baby is screened and is also determined to be safe, because the inheritance can be unpredictable in this disorder.
Okay, we are wrapping up our final questions right now. I'm going to try to do just 3 more. So Brian's I'm going to read this because I'm going to butcher the words. I'm sorry. Brian's aorta was damaged at the brachiocephalic insertion as a result of trauma, but not immediately. 1.5, it says not 1.5 months later. Why would it take so long if the true lumen is only 20% patent? The false lumen has a clot matrix through the arch, and the bottom of the false line is fully patent to right renal artery. How dangerous would repairing this be? Hope you understood all that.
So what I think happened is he's describing a dissection that extended all the way down his aorta, and might have compromised the vessels that comes off his aorta, the branches that go into the head and neck.
Okay.
If that's the case, the repair can be complex because they have to restore blood flow to those head and neck vessels, usually with a bypass. So it does prolong the repair and make it slightly riskier than a repair that just involves, say, the ascending or descending aorta. Now, ascending repairs tend to be the most straightforward because there are no vessels that come off the ascending aorta. So you just need to clamp it at both ends and replace it. The arch is very difficult. And so the discussion would be, how much risk does it add? How much time does it add to the operation? And what are the effects going to be on the rest of my aorta? If he has a dissection all the way down and you replace that arch, even if it's replaced, he still is at risk for dilation and dissection of the descending and abdominal aorta.
Okay. Anybody ever get an allergic reaction to a dacron graft?
Yes, there are in fact several case reports. It's extremely rare, but if you look in the surgical journals, there are patients who've had to have their dacron grafts removed because of an acute allergic reaction. I've never seen it. Fortunately, from what I can tell, it's microscopically rare, but it apparently has occurred.
Okay, and then one last question, and then if anybody else has any questions and we did not get a chance to answer it, even if you typed it once, if we didn't get a chance to answer it, please type it out again, and Dr. Prakash, you have free reign here to just keep reviewing the video and answer what you'd like, or send me a message, however it's best for you. But there are some people in the community that tend to feel very uncomfortable, whether it's months to a year to a couple years later, back pain when standing for a long period of time between their shoulders, their shoulder blades. I know personally I ended up with a frozen shoulder after surgery. There's a lot of people that just don't feel right in their chest and their sternum, and they just live with ungodly amounts of pain, and they're told it's anxiety, it's in their mind, but there's truly nothing wrong with them from a circulatory sense. But have you heard patients describe this, and do you have thoughts about that?
Yeah, absolutely. So when we see someone who's had surgery, the first thing you notice in their images of the chest is how much scar tissue builds up around the repaired aorta. That scar tissue is just from inflammation. That inflammation doesn't go away anytime soon after repair. It can linger for months or years. That inflammation, I'm convinced, is what's causing their symptoms. They're having a systemic inflammatory response that leads to things like joint pain, this discomfort you're describing, trouble with breathing, the feeling, this unsettled feeling that many people describe. Mm-hmm. And I think it's related to this really prolonged healing process we need to find ways to speed up the healing of our patients. Right now, we don't really know why certain people take longer than others to heal. It should be something that we investigate.
Okay, so any suggestions for that, or a specific type of doctor that somebody could see?
So I think one of the things I've done a lot with my patients is physical therapy, and we work with an orthopedist who specializes in Marfan and related disorders for the back pain. A lot of times he's able to brace them and also do physical therapy with them that people report greatly improves their quality of life. I really try to avoid using drug therapy for chronic pain. I think it doesn't, in the long run, benefit in terms of their activity level, their benefit, their pleasure with life. And so we try to do everything we can to get them active and able to enjoy things again, because there is that anxiety on top of all that that makes it harder for them to engage after something traumatic like that happens.
And one final question, because we just talked about physical therapy. Can somebody do plank position exercise if they've had, whether it's an abdominal or thoracic dissection? Is that an okay? I would think not, but you tell me. I don't know.
So I think the answer to that is certainly yes. And the reason why is because the fundamental property of a plank is very different than lifting heavy weights. You're not engaging a large amount of force in a very small time. It's sustained contraction. And that sort of thing is very different than the kind of force I was talking about earlier. This very sudden, large change in force. As long as you're doing sustained movements and slow movements, I think it's fine. There's no evidence that that by itself is going to dramatically increase stress on the aorta.
Okay. Well, I can tell you that I've been reading the messages, scrolling through. We've got people crying. They just feel so relieved to know that what they feel is normal. And you've done a great job again here with us tonight as you did this symposium. And I now that we know what we're doing, would you join us again at another time for another event in the future?
Sure. I'll try to do better next time. I don't know what happened.
It was me. No, it was totally me. I had no idea what I was doing, but I'm going to write down so I don't forget, because my pump head's so bad. I'm going to write down exactly what we need to do so we get it right the next time. But Dr. Prakash, thank you so much for taking this much time out of your evening to join us. We really, really greatly appreciate it. And if I see questions and need your help, I will shoot them over to you and we'll get them answered, and look forward to doing this with you again in the future and maybe seeing you at the next symposium.
Sure. Well, thank you, everyone. It's been an honor, and I really enjoyed being at the symposium. I'll do one of these again.
That'd be awesome. Thank you so much. Have a good evening.
Bye.
Take care. All right, everybody. Thank you so much. Have a great night. And this video will be up to be reviewed over and over and over again. If you have questions or we didn't get a chance to answer them, we'll do our best. Thanks so much. Have a good night. Take care.